Thank you all very much for joining us. My name is Andrew Romanoff. I was the Speaker of the House and the President of Mental Health Colorado. I'm running for the U.S. Senate, but I'm here first and foremost as an American concerned about this pandemic and doing everything on our part to survive. We're interested in offering resources to you. You can find more details on our website at andrewromanoff.com. We're holding town halls like this every Friday at noon and Tuesday at 5 p.m. Mountain Time. You can join us at Romanoff 2020 on Twitter or Facebook. You can also find us, as 2,000 of you have so far today, on Zoom. And you can participate by RSVPing through our website, again, at andrewromanoff.com. We're here today to talk a little bit about the healthcare system, how it is handling this pandemic, and what changes we might make going forward so that we can continue to protect lives, hold down costs, improve the quality of care, and expand coverage in America. I recognize that's a tall order for a 60-minute conversation. This is not the first time we've had this discussion. It certainly won't be the last. We'll be joined in the weeks ahead by other experts, and we're inviting you to share your questions as well. You can do that on Zoom in the chat box by typing into the Q&A section. You can do that on Facebook Live. If you're listening into this conversation by phone, unfortunately, we won't be able to take your calls. You can try on Twitter to send questions our way as well. I want to say I'm very grateful for everyone, not just the folks on the panel, but everybody in our audience and everybody across our country who are doing so much work in order to protect ourselves, to improve our public health, and to save lives. I'm very grateful, and I know I'm joined by a grateful nation. We're joined today by a panel of experts, and I will introduce them. I have them on my screen in Brady Bunch fashion, so maybe I'll introduce them in that order. Dr. Lauren Hughes is Associate Professor at the CU Department of Family Medicine and State Policy Director at the Farley Health Policy Center. I appreciate your joining us. Dr. Colleen Casper is Executive Director of the Colorado Nurses Association. She's joining us as well. Catherine Mulready is Vice President of Legislative Policy and Chief Strategy Officer at the Colorado Hospital Association, where her colleague Ben Anderson also works. He's the Vice President for Rural Health and Hospitals. And one of the priorities we want to bring today is a discussion of how this pandemic is playing out in the rural parts of our state. And finally, we're joined by Elizabeth Baskett, who will share several different hats. I describe her as a healthcare policy entrepreneur. She's also a principal at Baskett Consulting. So I want to say thanks to all of you. I really appreciate your time and your commitment to this cause. I want to start where I ended last night. Like a lot of folks in Colorado and across the country, I walked outside at 8 o'clock to howl, to join in a show of support for healthcare workers and other heroes who were fighting on the front line of this pandemic. So we united our voices in an imitation of wolves, but that's not enough. It's pretty clear from the conversations that we've had that there are a lot of healthcare workers who are howling as well for more personal protective equipment and support for the safety and precautions that they need in order to do their jobs for our sake. And I want to ask any of our panelists who are comfortable to weigh in here, why don't enough of our healthcare workers have the PPE they know they need right now, and what can we do to make a difference in that regard? Does anybody want to weigh in on that question?
Andrew, I'd be happy to. Can you all hear me?
I think so.
So it's just a supply and demand issue. Our distribution or supply system was not really set up for a global pandemic this way. And so when there is a shortage, and that shortage seems immense and really immeasurable right now, the supply chains break down. And we know that when we start seeing academic medical centers looking for alternative sources of PPE to protect their workforce, and workers not coming to work or struggling with coming to work because they don't feel safe at work. And we see that even more acutely at the end of the supply line, which is where our rural hospitals find themselves. So if it's difficult, if a mask is difficult for a system like University Health or Children's to find, it becomes near impossible to find on the Front Range, or sorry, not on the Front Range, but on the Western Slope or in the Eastern Plains. And part of it is that there are now universal masking precautions that are being put into place, and so we're needing to use more of that resource than we ever have previously. And frankly, that's just, those resources don't exist at the level that we need them. And I think it's going to become even more acute, Andrew, moving forward, because to get back to normal, whatever the new normal is, it won't be the same as it was before the beginning of the COVID crisis. But to get back to providing services in hospitals, that's going to require more personal protective equipment. And so we're grappling with that right now. How do we increase what's in the supply line, and how do we appropriately allocate what's there in an equitable basis?
Are we doing everything we can at a national level to mobilize the manufacture of this equipment? I know it takes longer to produce a ventilator than a mask, but are we doing everything that we possibly can around the country to get these resources in place right now?
It's difficult to know if we're doing everything we possibly can. We certainly have seen some conflict between people that, or groups or entities that are on the same team, really advocating for PPE, and folks competing for purchases that really are looking to serve the same populations. There's probably some inefficiencies in the system that we're working through as a nation, and yeah, we're pivoting as we go, it seems.
And Andrew, I would add a couple of thoughts there. From a policy perspective on the federal level, would love to see greater and fuller use of a key policy tool, which is the Defense Production Act, to really work with our private sector, for example, to switch production to the type of protective equipment and gear that we need on the front lines of this crisis. And also, secondly, just better coordination between the federal government and our states to really fine tune which states have a greater need for this equipment at this time, and to ensure that they are the ones that are receiving the equipment that they need compared to their peers. It might be lagging a little bit behind in terms of the surge and peak of cases.
And this is Colleen Casper with the Colorado Nurses. I also think this is an area where everyone on this call can participate in making a request of their state and federal representatives to get behind the Federal Production Act request and fund it and manage it and deliver sooner rather than later.
Can I just ask a question about later? Sorry, I cut you off there, Catherine. Did you want to wait?
That's okay. I was just going to kind of wrap up maybe by acknowledging that while we're doing a lot, right, locally, across the hospital and other healthcare institutions, and at the state level and at the national level, I agree with the other panelists that could we be doing more? Absolutely. Part of what we have very poor line of sight into is the distribution formula or the algorithm that the feds and frankly even state to state are using to distribute PPE and other resources through the state and national stockpiles that we have. There's been a little exchange this week about whether there's some political motivation behind some of those distributions. I think the reality is, without the transparency of understanding how they're making decisions, we're making those assumptions. And so 100%, let's fully mobilize and utilize the Defense Production Act, but let's also be transparent with how we're allocating resources. And the reason that that's so valuable in the COVID pandemic relative to other historical events we've experienced is because this isn't a traditional emergency. Traditional emergencies tend to be localized and short-term in duration, and the rest of the economy is still fairly functional. What we're experiencing in COVID is not just a state or a national, but a global emergency. And so demand, as Ben was saying, is so far beyond the supplies we have that we need to have, I think, kind of a common understanding of how the limited supplies we have will be doled out, and there will be consequences for that. And we don't know how long we'll be dealing with that. We've seen some disruptions in our traditional supply chain, which has impacted hospitals pretty deeply, because what we used to be able to rely on to protect our patients and our healthcare workers, some of those orders aren't getting to their to the hospital for which they were intended. And so I think really kind of focusing in on not only making sure there's a lot of supply, but when there isn't enough supply, making sure we're clear about how that's getting distributed would be two kind of pieces I would add.
You and Ben both touched on, at least in passing, on the competition that we saw among states and between the states and the federal government, and the politics that played into that. And it does seem like a particularly horrible time to engage in that kind of political activity. Is there a lesson that we can draw from this experience and put ourselves in better position for the next crisis, which will hit at some point, so that we're not stuck having the federal government apparently swipe ventilators and then return the ventilators and then put ourselves at risk?
I think the comment I'd make there, Andrew, is, and I appreciate all that Catherine just said around the need for distribution algorithms. That determines if people live or die. But I think broader, the lesson we can learn is that systems heal people and systems harm or kill people. Systems full of well-intended people. Because not all of those breakdowns that were mentioned earlier were intentional. I mean, most folks that are in this are in it with good intentions to try to help other people, but we don't have systems that are talking to each other consistently, or some do, some don't. And so I think having a preparedness plan in place with distribution algorithms, as Catherine mentioned, that are based on objective, credible criteria, will remove even the perception of politics in this, and it levels the playing field if they're well thought out in advance, and it's got to be more complex perhaps than how many people live in a city and how many of them are above 65 and how many beds are in a city, right? Which is one algorithm that's being considered or used at a federal level. It's got to be more complex. I mean, we have to consider the prevalence of a disease. And of course, when there's not testing, then how do we do that? We just got to really think through a system that prevents some of this harm from happening in the future.
Because just to follow up this point, a couple folks are asking on our Zoom chat. And again, if you're joining us, you can type in your questions either on Facebook Live at Romanoff 2020 or on Zoom if you got the link. A couple folks are asking, whose job is this? The state, the federal government, when it comes both to buying the PPE equipment and, for that matter, testing? Because I think there's a lot of confusion about the lines of responsibility here. Can anybody speak to that?
I'm happy to start. So, you know, I think the reality of the answer to that question is it's kind of everyone's responsibility. It's probably not singly the healthcare system's responsibility or singly state governments or singly federal governments, but really we have to work together in collaboration. And I think where I've been most disappointed in some of this debate around competition with one another for resources is that we're not leveraging the power of bringing people together to share supplies and share resources. And so, you know, maybe if we can highlight a couple of good stories from this week, we are seeing states start to voluntarily share with one another ventilators, right? You take these 100 ventilators for a month and we'll get them back when we have a surge and that kind of thing. We can make that work in Colorado, and I think we can make it work nationally, potentially even globally if we need to. But I do think that there is a need for a sensible coordination of policy, even if it isn't always kind of top down from the federal government. Sometimes it should be that way and sometimes it shouldn't. I think we're all grappling with kind of the need for what some people call local control or local flexibility. You know, we want communities that aren't hard hit by COVID to be able to get back to some semblance of the new normal. But at the same time, we need to acknowledge that there are places harder hit than others, and we need to flux kind of the supplies, whether that's testing or PPE or ventilators or other supplies, to where they're needed most. And doing that requires some level of coordination. So I think at the end of the day, there's probably a lot of different pieces of responsibility, and there's probably going to be a lot of blame to go around. But I hope that there's also some good stories in here where people did step up and come together to solve some really challenging problems.
I appreciate your point on creativity, and I'll just press the question because it seems like we're building this airplane in the air.
Right.
The response seems largely improvisational. So Governor of California steps in. There's got to be a better way to design this going forward. I don't want to shortchange the importance of solving this problem now as we're trying to imagine a different system. But it's hard just at a lay level to distill much rhyme or reason from this approach. Somebody else was weighing in on that as well.
Andrew,
Elizabeth,
I
either one of you.
appreciate that. I appreciate that question. And I think most certainly I am incredibly impressed with public health and clinical providers on the front lines and their ability to innovate and quite truly build the plane while we're flying it in terms of coming up with innovative solutions that work in their environments. And that's not to be discredited, and those individuals are absolutely to be applauded. But I think the challenges that we are seeing in our response in the country to COVID-19 really highlight that this is related to a lack of planning, a lack of preparation, and a lack of practice. Before I moved to Colorado just a couple of months ago to take these positions, I served in Governor Wolf's administration as a Deputy Secretary of Health in the Pennsylvania Department of Health. And I credit my former boss, Secretary of Health, Dr. Levine, with her sentiment when it came to public health preparedness and emergency response. She said, what keeps me up at nighttime is this exact scenario. Like, what's going to happen? And so we routinely engaged in preparedness planning and response. And I think moving forward, we need to ensure that we restore public health leadership at the federal level. We need to fully invest in public health preparedness, and that includes research and development and the importance of continuous surveillance. We live in a global world that it's very easy to travel. We will see global infectious diseases again in our futures. In my lifetime, I have seen MERS, I have seen SARS, I've seen Ebola, and I've seen Zika, and now this novel coronavirus, which clearly is the most severe. But we need to learn from this, invite others to the table to join us in preparedness conversations beyond public health and medical professionals. What about childcare workers, postal workers, other delivery service providers, our grocery store clerks, small business owners? They need to be a part of this conversation moving forward. And we really need to have a coordinated plan between states, among states and the federal government. And we need to routinely practice that in terms of resource sharing, personnel, who's a leader, who's on first base, who's on second base, et cetera, and to practice communication channels among each other and then with the public.
I want to make sure I give Elizabeth a chance to weigh in on this as well. Were you trying to jump in there, Elizabeth, earlier?
Sure. I would just add that, I feel like we've largely underestimated the career federal experts that we have inside of our agencies. We have experts in public health and epidemiology, and this administration has failed to leverage the expertise and the plans they've already made. It's not like we haven't worked on public health epidemics within our federal agencies and don't have the resources and knowledge on how to combat this. It's that the virus wasn't acknowledged early on, and we weren't able to prepare as early as we needed to. And I just hope going forward, that is a lesson for future leaders such as yourself, that you've got a brain trust of experts working on the federal level, and that's who we need to be leaning on and working with to get through this.
Yeah, we're getting a number of questions along the same lines. I will point out that, and we'll devote a future town hall to this subject, to the extent that we fail to take climate action, the risk of another pandemic goes up, right? We've already seen warmer temperatures driving the spread of disease-carrying species around the world. So this may end up being closer to our new normal. And to that point, Lisa's asking, without testing and with some people being carriers, how do we ever expect to be in the world again?
That's a hard one. I'll take a swing at it, knowing that our colleagues will fill in the blanks or back me up. How does that sound, Lauren? Dr. Castro. There will be a new normal, and Catherine and I were on an earlier call where we said the words normal within air quotes, right? We're going to have to ease back into this in phases, and the sooner we can do that safely, of course, the less damage to the economy. So that involves clear direction from state and federal government and from epidemiologists and other health leaders. That involves the equipment, the personal protective equipment, both for healthcare workers and for the general public, which include hand sanitizer, which include face masks, which include other forms of PPE. It involves the availability and so the creation and distribution of those things. And we'll ease back into this with social distancing. And then as we either develop herd immunity or a vaccine is developed, we'll figure out what that new normal looks like. But we can still, with deliberate planning and really solid leadership, avoid future harm. We're not stuck with a lot that we have right now. We have the ability to pivot and really do some remarkable things. And to Catherine's comment earlier around celebrating the wins, I fully believe in that. We're seeing this at a local level. We're seeing it at a state level, and at some level, multi-state, like Catherine mentioned. But we have Angel Flight planes with 50 volunteer pilots and planes taking PPE all over our state, several missions every day, dropping off at multiple sites when there's no other way to get these donated supplies, including ventilators, things like that, out to rural areas. The ground transportation for those missions are being managed by urban people from the Front Range, volunteer pilots who are now grounded or not working, people from some of our urban systems that are volunteering their time to coordinate those things. These are people that don't know each other personally, but we're seeing a crisis like this bring out the best in people, and we'll continue to see that if we choose to engage and put our differences aside.
Just to that point, Sandra's writing in to say, my mother just survived the virus thanks to the amazing care of healthcare workers at Littleton Adventist Hospital. What's the best way for citizens to thank and support our healthcare heroes? We're so grateful and want to contribute. Does anybody have a quick suggestion on how to send thanks?
That's a great question. Well,
Howl.
certainly we can follow your lead and howl at 8 p.m. So that's not happening in my neighborhood, but it is happening where my mom lives, and she was totally taken aback by it the other night. So we're going to start it here too. But really, we've got so many folks working on the front lines and 100% healthcare workers in hospitals, but we've got a lot of other people that are essential workers showing up for work. Our grocery workers, our restaurant workers that are continuing to put food out for folks. We've got a ton of folks working in food pantries and anywhere else. So whatever strikes your heart, and if you're able, send some digital gift cards. Those are great. If you do want to help healthcare workers directly, I know a lot of hospitals have been taking in kind of gift cards that they can then share with their staff so that they can grab something on the way home or bring food into the hospital. We're obviously really focused on infection control, so don't drop anything off at a hospital like you might have done in past days, a plate of cookies or whatever. But certainly anything that can help relay aid to anyone who needs it. And healthcare workers are 100% dedicated to treating patients in this pandemic, but they're by far the only folks that really need our help right now. And so just maybe a thought.
This is Colleen. I just want to add, send an electronic email to the facility administrator and use social distancing and hand washing. Keep yourself healthy.
If I can just add on the policy level, because I think that's really important too, and I know your audience is very engaged politically, we need to think about the policies to support these individuals. Hazard pay for healthcare workers who are risking their lives. I have a friend that works at Costco. They are giving her hazard pay because she's risking her life going in the infection of her family. So thinking about not just the healthcare workers, but also those working in the grocery stores. They are our army. They're at war. So not only do they need the PPE, but there's policies being considered on the federal and on the state level right now of how do we protect these workers and how do we keep them safe? We also need tests. We need a lot more tests. And this relates to your last question about going to the back to normal. We're not going to get anywhere until we really have ubiquitous testing across all of our communities. And we need them for our healthcare workers too. I have a friend who's an emergency room nurse who thought she had it, never was able to get tested because that's how low we are on tests. And this is not a comment on the governor at all. I think we have a national shortage of testing. But that's another important thing to protecting our workers, is making sure they're getting compensated, taken care of, and themselves are safe.
I appreciate that point, and I just want to underline real quick. So we have heard, stories of food workers being treated to complimentary hot dogs and sodas instead of hazard pay or bonuses or paid sick leave. So I don't think anybody's going to suggest, which I'm not suggesting, that a thank you note is adequate substitute for the policy changes that you're suggesting, Elizabeth. Right. And to the same point, Ginger's asking about getting healthcare workers tested. She writes, our daughter's a doctor at North Colorado Medical Center in Greeley. It would really lower her anxiety and fear if she knew she was negative. She has other symptoms, but since she doesn't have a fever, she can't be tested. When will testing get quicker results? So 2 questions, I guess, for the group. One is, why don't we have in place a national policy of universal testing? And second, if we had such a policy, would we actually have enough tests? And third, would the answers come quickly enough to do as much good as we need? Does anybody want to tackle any of those questions? Universal testing, the supply of tests, and the timeliness of the results.
Yeah, so I'd start by saying the supply of tests or lack thereof is really driving the policies that we do have in place right now. So I'm a huge supporter of universal testing. We know that testing is one of the things that's going to be a precursor to getting us back to air quoted normal. But we just don't have the supply or the testing capability to do that now. I think there was a good article in the Colorado Sun this morning that indicated that the state's ability to first run the test was in late February because they were dependent on the CDC for sending them supplies that ultimately turned out to not run accurate tests for the first couple tries. So the supply is driving the policies right now. We need to get to universal testing, or at least kind of cluster-based population testing where we're seeing outbreaks if we can manage the spread of this disease. But we need supply, and we need it to be accurate and timely. And right now, I think we're still facing delays, even though we have tiered priority for testing to healthcare workers and those who are inpatients in hospitals, in Colorado at least. We are still facing testing delays of 5 to 7 days, and people who are in the community that think they might have symptoms may or may not be able to get a test right now. And so that's a huge problem, but we need to increase the supplies first so that we can change the policies to make the policies work.
Can I just ask, and again, put this to anybody on the panel, which country is doing this best? And
South Korea.
Why can't we, South Korea.
South Korea.
In Germany.
Yeah.
And South Korea and Germany, I hear?
I just heard that Canada is doing 650,000 tests a day, and that they now have it down to which grocery stores have higher infection rates, which neighborhoods have higher infection rates. That kind of capability, I think, is essential for being able to reopen our society.
Somebody else Rebecca's writing in with a pitch for Iceland. So what are Canada, Germany, Iceland, and South Korea capable of doing that we're not? Or what's stopping us as the richest nation on earth from following the lead or taking the lead that these other countries are demonstrating?
So in Germany, one of the things they did right from the very, very beginning is that they were paying very, very close attention to what was happening in China starting in December. And very, very early on, much earlier than what we did, they started developing their own testing capacity and really ramping up that production. So they are much more liberal in terms of their policies with testing, not restricted like what Catherine was mentioning right now in Colorado to healthcare workers or those we might be considering admission into a hospital. Anyone that may potentially have been in contact with someone that could have COVID symptoms, either confirmed or suspected, is generally able to get a test. So they were very much more anticipatory in their planning and ramping up test production than we were from the get-go. So that would be, I think, a key factor of success for Germany.
Someone else is pointing to New Zealand as an answer. Anybody else want to chime in on lessons that we can draw from around the world? I know Americans are sometimes reluctant to acknowledge that other countries may be ahead of us in this regard on any field.
And
But
I'm
it's pretty-
sure Ben or Catherine could speak to this, and probably Elizabeth too. We have to fund scientific research and build a system of public health. Systems can harm or help people. And if we don't build that and fund it, we're going to repeat this.
Yeah, well, I got you on the
Yeah,
line there,
it's the
Colleen.
investments that we make in our society. Sorry.
Go
Correct.
ahead.
Yeah.
So Colleen, you may want to weigh in on this as well. In addition to testing, and I don't want to leave the point altogether, Ginger's suggesting that we get healthcare workers' student loans forgiven immediately.
We have that request, and I believe it's part of the stimulus version 4.0 that's currently being discussed at the federal level. So there's great awareness of it. We just have to work it through Congress and the Senate, probably more importantly.
And I can speak to my own fairly substantial medical school loan that I still currently have. And I just received communication from the federal government that given provisions already in some of the response packages, that they've reduced interest rates to 0 between now and the end of September, and that they are putting all loan payments on administrative forbearance through the end of September. And of course, it's all subject to change with potential 4th package emerging, but those are some, clearly it's not being forgiven, but there are, measures are taken to sort of mitigate the impact right now during the height of the crisis.
Thank you.
Are the loan forgiveness programs an approach that, I guess it depends on who's making the loan, that the state, the government, or only the federal government could adopt?
I think there's flexibility depending on availability and political will and funding and so forth for loan forgiveness approaches to be considered as practical policy solutions at the state and the federal level, but it certainly depends from state to state.
So I'm going to jump through a series of questions, and I'll apologize in advance for not getting to all of them. Zoom moderator was not the training I took at school. So we have about 2,000 folks on this call and about 200 questions that are coming in through the Q&A box. I was going to encourage folks to type their questions into Zoom and Facebook at Romanov 2020, but I might discourage you at this point because I'm not going to be able to get to them all. Lori's asking if there is a wait time for people who think they have coronavirus to get the test in order to avoid false positive reads. Is there such a wait time?
So I think there are a couple of challenges with testing. One is supply. 2 is production availability and production turnaround and kind of the backlog of production. And 3 is there have been some reports of inaccurate test results or false negatives. We know that at least a portion of those false negatives are likely due to sampling error. A large chunk, this is gross, so sorry. A large chunk of the tests that we're doing now are dependent on nasopharyngeal swabs, which you really have to jam up your nose and kind of root around. And I'm seeing Lauren's face cringe on my screen. And you have to do it on both sides. And if you don't kind of dig deep enough, you might not get the right kind of swab, and that leads to a negative test or a potentially false negative test result. Because of the limited volume of testing supplies, yes, there is a test. We do not have in Colorado, or I don't think in many places across the country, kind of rapid turnaround, universally available testing to the public that can kind of determine whether they merit a test. We have kind of these testing thresholds where you can only access a test if. And so it's the focus on the tie is really important, that until we eliminate all those barriers to testing, we can't get back to any semblance of normal life, because testing is what's going to help us identify and isolate clusters of breakouts, so that we don't have to go back into full economic shutdown again. But we just don't have the supplies to eliminate those barriers right now.
Are any of you familiar with the work that's going on now in Telluride and other parts of San Miguel County? I know we talked a little bit about the international perspective, but just to localize it a bit, the status of that effort and its success to date?
Yeah, I'm happy to start, and there might be others. So huge credit to the Telluride Foundation in San Juan County. They're doing broad, what we call serological testing, which is testing for the antibodies that the disease creates in your body. It helps them know if someone had it and therefore has the antibodies that they potentially can't get COVID again. We're learning a lot about this disease every day. And so there have been some conflicting reports, I would say, about whether you only get it once and you'll never get it again. So that level of community testing is really important, kind of on the public health side, the epidemiological side. It will not help people know if they have the disease right now and could or couldn't spread it to other people. It's really kind of an after the fact test to see whether you've had it. But it will be a really important component of response. It's just kind of a different kind of testing than the kind of clinical testing we've been talking about mostly on this call.
And to follow on to what Catherine said, it's really important to understand the differences between testing for active disease and testing to see if you have been exposed and recovered and potentially immune to coronavirus. They have different purposes. Testing for active disease does not help us with the clinical course of the disease because we do not currently have specific treatment for coronavirus. We do not have a vaccine for coronavirus. But testing for active disease helps us identify cases, potential exposure, and to do what we call contact tracing in public health sort of lingo. The type of testing that Catherine was speaking to in terms of serologic testing helps serve a number of potential purposes. The first, and some of you may have been hearing this in the news, around experimental treatment with donation of plasma from someone who has been exposed and recovered to those that are critically ill. It also will help us understand, like for healthcare workers, when is it safe for them to return to work and when? And it also will, at the end of this, help us have better and more accurate statistics about the coronavirus with, for example, mortality or death rates. So different types of testing, different approaches, they all give us valuable information, but different types of information.
Thank you. Just to do a time check here, because this conversation could go on for more than the hour, and I'll keep the panelists who are willing to stay past the 1 o'clock stop that we had originally intended. But if you need to sneak off, we'll understand, and we'll thank you in advance. Two questions I'll try to combine here from Kira and from Brian. One, if we know people who have access to supplies for immediate delivery, who do they contact? That's the first question. Let me pause there. So, and I'm getting similar questions on Twitter and elsewhere, folks who have supplies. I've been steering some people at least to the Help Colorado Now site. I don't know if you all have a different destination in mind. Do you?
Well, this is Colleen. No, I do not have a different destination. I would definitely be in contact with your local county public health department because we want to make sure that they're safe and effective equipment. So it's helpful to have people provide PPE. And from a provider perspective, we want to make sure they're effective. So the governor has actually established a pretty good testing process to assure that products coming in are safe for the providers to use. But again, the local, state, county health departments.
So the state, Colorado Department of Public Health and Environment, or a local county health department, or, and maybe Seth, you could put this on the chat box, helpcoloradonow.org would be places to turn. On the flip side, Brian writes, many of my constituents in Western Colorado have fallen prey to scam websites offering to sell PPE for personal use. This is just a warning to all not to fall for these offers without confirming that the website and the supplies are real. Have you all encountered that risk?
Yes.
I've seen that, and just in general, greater cybersecurity concerns and attacks. So all consumers should be aware if something looks or sounds suspicious, it likely is. So of course, do not give your personal information in any way, shape, or form in a site that you do not trust or does not look trustworthy.
To add to that, Andrew, healthcare organizations are experiencing quite a bit of gouging that's going on. I mean, there are some vendors that are calling saying, I have access to so many N95 masks, which are the respirator masks that are so important right now to healthcare workers. Yeah, we'll sell them to you. Initially, the quote is $2, and then when you actually get down to it, it's $7 or $8 a piece is what they want for them, and they're really exploiting the need and the vulnerability of healthcare workers. And so this is something we've relayed to our federal delegation and are continuing to be mindful of. But this, in addition to all the other financial pressures that healthcare organizations are facing and the danger that healthcare workers are facing. We're seeing this go on. So I think engaging your representatives and senators and letting them know that this type of thing is going on, that need to address it, is another way for local folks to get involved.
Why are COVID-19 tests not offered at no charge in Colorado? La Plata County, one person writes, negotiated testing for residents, but it's $75 a piece, which is $300 for a family of 4. Why shouldn't, I mean, I know we made a pitch earlier for universal testing. Shouldn't it also be free? How do we make that happen?
It should be free. So depending on your payer, you know, depending on who your health insurance is, testing is free for all populations. I think this whole experience, though, shows us the gaps and the holes in our healthcare system, right? So people who are uninsured naturally are going to avoid getting tested because they're afraid of the costs. And we're having a really hard time getting the word out to the community around how to get tested and the fact that it is free. Because there are so many different healthcare payers, right? So the commercial plans were already mandated by the feds to pay for testing. Medicaid has already said testing is free. Medicare has already said testing is free. Self-employed testing is free. And then, self-employed insurers. And then also the uninsured can get testing for free. So maybe talking with your primary care doctor around testing is the general advice that the state is giving right now. The other thing is the nurse advice line. So if you go to the Colorado Department of Public Health and Environment, there's a website all for coronavirus. And on there, you can click on testing and it will give you information around testing, where to go, who to talk to. But the best source is your primary care doctor. And I would invite other panelists on that, but that's been my understanding.
We're going to devote a town hall to a discussion of universal single payer healthcare, which I support, and figure out if not just the testing could become free under a scenario like that, but also the treatment. And I don't just mean the treatment to help folks recover from this disease, but the collateral care they need, including mental health care, which is likely to be one of the consequences. We've seen a 9-fold increase, for example, in calls to a federal helpline as people experience increased rates of anxiety throughout this crisis. There's a couple other questions along these lines. Given the abdication of the federal government, Lee writes, in coordinating the distribution of supplies, has there been any discussion of multi-state compacts to address the issue? And I know
that's a great question. There are, so in Colorado and in general at the state level, there is a very coordinated distribution from the state's emergency operations center that flows down through local public health, and information flows that way. We have seen some states band together to do joint purchasing. And so, for example, in New York, in the tri-state area, so New York, New Jersey, and Connecticut, they all banded together to purchase supplies to then supplement their distribution, and I think are managing that in a coordinated fashion. I think, where we're a little more geographically isolated out here in Colorado than they are back east, it's a little more difficult to do that in a way that makes sense, but it's certainly an area that we have looked into, and there is the potential for some of that moving down the road.
There are a couple offers that are coming in for help here. Nate writes that he's creating a collection center in Denver to collect, sanitize, and package PPE from local 3D printers. So the question is, what type of PPE do hospitals need now? We've had problems with hospitals turning away 3D printed PPE. And I'm going to suggest we figure out a way to connect Nate to Catherine and Ben and anybody else who can be helpful. And maybe Seth, I'm just doing this on the fly here, but if we can capture the Nate Monroe's question there, it'd be useful to connect him, because I want to make sure we're taking advantage of these 3D offers. To me, at least, not being an expert on this field, 3D printing may be one of the worldwide solutions to these pandemics going forward, because you don't have to rely on a centralized supplier production chain. You could literally print a lot of this equipment at home or in a business. When is the peak? Go ahead.
Just one quick thing. I've seen a number of questions come in regarding excuse me, retired nurses. There's also a mobilizer tracker is what it's called now on the Colorado Department of Public Health site. I'll send you that link so that people who do want to come back into the workforce, there's a way to do that.
Is there, and I know there are a lot of folks joining us on Facebook and Twitter. I want to thank you as well. In case you're interested in the answer to the question, I won't postpone it. But does anybody have an answer to this question? Shields, masks, what do you need? Are hospitals turning those away because they can't?
Yeah.
I can speak
Oh,
to
go
that.
ahead,
So,
Ben.
yeah. So the question is the efficacy of the equipment, and Colorado State University has set up a testing center, and of course we've got folks getting in line to try to get their equipment tested to make sure that it meets traditional standards for PPE. But alternative sources of PPE are being introduced as well, and there's varying levels of comfortability within with clinical workers or clinicians around wearing alternative sources of PPE that have not been tested for efficacy. And so out in the rural areas where again we're at the end of the supply line, we're getting more requests from places like that because they worry about running out of their last disposable mask and having nothing, and that's like showing up with a handful of rocks at a gunfight. That's no good, and so they're really wanting to make sure that they have some coverage. The efficacy, I would imagine, in some of these alternative sources of PPE, 3D printed or not, would vary, and we don't have a way of knowing what's good and what's not and what's actually protecting. And so it's really important that we're not creating a false sense of protection for healthcare workers as we're doing this. And so if somebody's going to put something on that has been homemade or made on the fly without being tested, that they know, okay, this is the source of it, this is what we know it does, this is what we don't know it does, and we know that in general, something's better than nothing. And so the resistance, Andrew, is probably coming from that. So you asked about what's needed. Face masks are needed, especially N95 face masks are needed. Traditional disposable surgical masks are needed. Gowns are needed. Foot coverings are needed. Hand sanitizer is needed. Disinfectant solution is needed. All of these forms of PPE or support are needed in our system right now. And because we are in a stage of crisis standards of care, we are considering things that we would not normally under typical terms consider, and that would be cloth masks and these shields that are 3D printed, things like that. So
is there a Ben? We just interrupt you real quick. Is there a list of these needs, or where they're needed, or how to supply them? And is there some? Again, do we go to the health department, or where can folks turn?
The governor has a PPE task force, and they certainly have their finger on the pulse. Project Cure, which was the beneficiary of the citywide PPE drive that happened recently, they know exactly what they're doing, and they know what's being requested out there. And so referring people to Project Cure, it's a great organization to support on an individual or an organization level. And when we are making requests to some of the most desperate healthcare providers in the state, same day they are responding saying, here are your N95s, here are your surgical masks, here's your equipment, here's your ventilator. They really have a good finger on the pulse of that. Now they're not a government organization, but they certainly are on the ground and they're seeing the demand as it comes in.
It's an international aid organization that happens to be based here. Maybe, Seth, we could put a link up to projectcure.org. I appreciate that suggestion. Along the same lines, Janet Farmer, who's the mayor of Mount Crested Butte, says in Gunnison County, we have seen some of the highest rates in the state, at least per capita. We've had 100 testing positive, close to 300 self-reporting. We haven't been able to test. We got some yesterday after we conducted a letter writing campaign to state officials that we needed more. What's the criteria the state's using for the distribution of these tests? Because again, the approach seems improvisational to suggest that you get the tests if you make enough noise.
Yeah, this goes back to the statement I made kind of when we opened up. For both the federal distribution and the state distribution, we don't have line of sight into the criteria they're using to make decisions about where any supplies go. Testing, PPE, ventilators, anything else. And so that does make it very challenging to adequately plan, or as she noted, get the the kinds of supplies that we need when we need them. What we do know is that there isn't enough supply to meet demand. And so we know they're making tough decisions. We just don't know necessarily how those decisions are being made.
So to the same point, Ken's asking if hospitals can step up, or how they can step up if there's not the funds to conduct constant surveillance at either the state or national level. We've seen the current administration requesting funding cuts to NIH and CDC. I know Colleen was touching on the importance of this research earlier, each fiscal year. This would be the case at the state level, depending on the governor. Does the National Hospital Association need to step up to tell Congress that it's necessary for the public good?
Yeah, absolutely. So our national counterpart, it's a separate organization, but it's the American Hospital Association. They are making those asks. We are big as part of the health infrastructure in the nation. The supply certainly in Colorado and nationally. We are strong advocates for public health. I know that in Colorado, our public health funding, which is mostly federal funds that come through the state, never really recovered after the recession of 2008, or the recession that started in 2008. And so we have underinvested significantly in public health resources that can help prevent these kinds of things, or at least help with our response to these kinds of pandemics when they happen in the future. So that's certainly on everyone's priority list for how we can prevent this from recurring.
And there were funds allocated in the Stimulus Bill 3.0 to expand the funding for National Academies of Medicine and the National Supply Chain and Stockpile. We realize it's not enough, but just so people know, there is action being taken by our federal representatives.
But to Catherine's point, it's important for us moving forward to not just be reactive in terms of our funding solution. So an issue hits, a pandemic like this, we pour a lot of money into it on a variety of fronts, as opposed to being proactive and stable, steady funding, particularly for surveillance moving forward, because we will have another infectious disease on a global scale at some point in the future. It may not be to this extent in terms of severity, but it will happen again, just given our global world. So it's important that we are infusing a stable, investing stably in public health preparedness.
We're not going to be able to solve all these problems, obviously, in 60 minutes, and I'm going to try to beg 15 more out of our panelists. But again, I know our feelings, if you have to sneak out, you all have been very generous with your time. And the 2,000 folks who are joining us on this call have been very generous with their questions. So I'll put in a little station break here. We're going to keep going a little bit past 1 with the indulgence of our guests. If you want to continue this conversation with me, you can do so by emailing info@andrewromanoff.com, info@andrewromanoff.com. You can join us every Tuesdays at 5 and every Friday at noon on Facebook at Romanoff 2020, on Twitter at Romanoff 2020, on Zoom, or you can get the details by going to the event page at andrewromanoff.com. We talked a little bit about the rest of the world. I want to talk a little bit about the United States in the past, and I think one of our panelists spoke to the need to put the country on war footing and the national mobilization that took place during the Second World War. At the same time, James points out, we've seen states and the federal government bidding against each other, and we're being victimized by price gougers. Prices have been going up several 100%, he writes. We, the taxpayers, are paying the price. In the Second World War, we had price controls. Why isn't that part of the conversation now? Draw a lesson from the 1940s. Or is that part of the conversation that you all have heard, price controls on some of these products that we need? Sounds like it's not been part of the conversation. Maybe it will be now.
I have not heard that being discussed, and I don't imagine it happening under the current national administration. I don't see Polis doing it either. But you never know. Everything changes day to day with this virus.
And with the president. This is very gently put. So along the same lines, Ken's pointing out that, and we're going to, I think, I don't want to try to do justice to this question, but tens of millions of people are going to lose their health insurance policies in the near future. We've already seen, obviously, more than 10% of the population unemployed. By some estimates, that figure will reach 1/3 of the population. How will hospitals weather the fact that health insurance companies will be playing hardball with hospitals over payments? Will this mean that hospital systems will have to pare back even essential services? I mean, if we are facing a Great Depression-like levels of unemployment, and to the extent that most adults in America rely for their coverage on their employer-based plans, and a number of those folks will then lose that coverage, What does that mean if you're running a hospital? How do we possibly handle that crisis in the making?
So where I'd maybe start with this is COVID is already having really detrimental impacts on hospital and health system financing. And I don't want to make it sound like hospitals are the only ones impacted in the health system. We're seeing safety net clinics and other healthcare providers really adversely affected. Partially that's because their kind of normal business is going away, right? We canceled elective surgeries to save PPE. And at the same time, we're seeing, as we've discussed, kind of exorbitant costs for keeping supplies in, additional costs for staff for build out of newly needed capacity. And so we know that this is going to be pretty detrimental to the financial operations of the healthcare system. Private insurance companies always play hardball. That's kind of part of what they do. And we will continue to provide care to those who need it, regardless of ability to pay. And we'll also fight back with the insurance companies to try to make sure that services are fairly reimbursed. One of the interesting things, though, is that this is the first economic crisis that the country has experienced since we put the ACA's Medicaid expansion into place. And not every state has Medicaid expansion, but Colorado does. And we should be really proud of that. And so while it is a travesty that folks are losing their jobs, we do have a safety net in Colorado, which is that if folks are unemployed, they can, and for a number of other reasons, they can access Medicaid through this time so that they do have their healthcare needs paid for. And that will help the hospitals get at least some level of reimbursement, although Medicaid and Medicare both underpay what it costs the hospital to provide that care. But that is going to be a key part of the safety net and making sure that the healthcare system doesn't crumble.
Can I just to press this point and maybe to offer a preview of a town hall we're going to be having in a couple of weeks. We've seen the federal government in the past make a commitment to universal health care. We just happened to pick the emergency room, right? In 1986, when Ronald Reagan signed a law called EMTALA, the requirement was that if a hospital wants Medicare dollars, it has to accept anybody who comes in need of emergency care. And correct me if my history is wrong here. At the same time, in this crisis, we've seen a commitment on the part of Democrats and Republicans, at least to some extent, to suggest that testing ought to be free, that some limited form of treatment ought to be free, even if they haven't delivered on that commitment yet. So does this crisis, a long way of asking, does this crisis make any of you personally or organizationally more sympathetic to a program of Medicare for all or Medicaid for all or universal coverage for more than just a single disease? As terrible as COVID is, why are we restricting the guarantee or at least the prospect of testing and treatment to the coronavirus instead of all the other conditions that afflict Americans? It's a big question.
The way I've been thinking about it recently, and I worked on the Affordable Care Act back in the day, 10 years ago, if you can imagine that. I know probably all the panelists did. I never knew that it was going to take a pandemic, a worldwide pandemic, for our country, our world to understand how critical it is that every person have health insurance. And I'll tell you right now, the people that are in the gaps, those who are homeless right now, those who are on the reservations, those who are on prisons, refugee camps, all of those folks who are not going to get tested will become everyone's problem. Finally, we have a situation, and unfortunately, where if we don't make sure people have access to healthcare, we're not going to stop the spread. So there's really no better commercial for universal healthcare than this pandemic. And what I hope comes out of this is a recognition by our society that people need basic access to services. And even if we add people to services now, a lot of them still won't get it because they don't know it's out there, about the co-pays and the cost sharing. So this whole experience is going to require our leaders and all of us to step back and say, how do we design a system that keeps us all safe? And really the only way to do that is just to make sure everybody has health care.
I'm glad that you mentioned, as one of the viewers is as well, that this crisis, while everybody may be at risk, some folks are at greater risk of becoming sicker and dying than others, and their ability to get the resources they need doesn't fall equally across the population. When some communities like African Americans, for example, in America have only a tenth the wealth of white families, it's pretty clear that the consequences of this crisis will not be borne equally across the population. Does anyone else want to weigh in? And if you can do so now and rejoin our panel too in a couple weeks, but just on this question around universal care, and I'll put the question a little more narrowly. Kyle's asking, would a national health service do a better job providing healthcare and the distribution of resources compared to the current piecemeal system?
I'm happy to weigh in a little bit, Andrew. So I think it's hard to know, right, is the answer to the questioner's question. And frankly, I think even in response to this, it's hard to know what the best path forward is or what the possible paths forward might be. Certainly on the hospital side, we are committed to making sure that Coloradans get the care they need when they need it. And generally speaking, we're not supportive of single payer healthcare because it threatens our ability to be nimble and respond to crises like this. If we were fully dependent on Medicare or Medicaid payer sources, we would not be able to do the flexing that we're doing now to make sure that we have the ICU capacity. That said, there are other nations in the world that have figured out different healthcare systems than ours and may work better. It doesn't mean that it stops the conversation about about kind of broad scale healthcare reform. And I think we should learn from not only this pandemic, but as Lauren mentioned earlier, the number of pandemics we've experienced in the last several years to figure out where we do need to make upstream investments in our healthcare system or our health system, and whether that's environmental or public health or anywhere else, other social policies, to make sure that we are not only providing people access to health care when they need it, but enabling people to access health throughout the course of their lives, even if it's not at the point of care. So we'll continue to be advocates for that and welcome your partnership. We always have.
No, I appreciate that.
Andrew, on this particular question, I take a different sort of perspective. And again, I'll remind the audience, I'm a family physician, so I believe in and support high quality primary care. And so when I think about like universal access to health and healthcare services, I think about functionally what is needed first, and then I think about ways to finance that secondly. And so I think this crisis for me is illustrating the incredible importance of having access to high quality public health and primary and preventive care. Like that needs to be, in my opinion, this is a personal opinion, needs to be universal in terms of access to those high quality services. And there are many ways one could go about financing those, but I think functionally that this pandemic is emphasizing the need for those things.
And I should say, so I don't get flooded with tweets and chats here, when I'm suggesting Medicare for all, I'm talking about a system that would strengthen Medicare by adding some benefits that aren't part of the package now, like dental, vision, hearing, and long-term care. I'm also talking about increasing reimbursement rates for Medicare providers, particularly in rural and other underserved communities. And you can find more details on my plan at andrewromanoff.com. I want to stick just with the rural part of that question too, because just as there are different parts of the population, as Elizabeth pointed out, that are bearing disproportionate risks from this crisis, it's pretty clear that we're having this conversation, most of us, I think, here in the Metro Denver area. What's the situation, from your knowledge, of rural Colorado, especially counties without hospitals or healthcare facilities, or even in some cases without nearly enough doctors, if any, to meet their needs, or nurses or other healthcare providers? How does this pandemic playing out across the state?
Well, I would look to Catherine to talk about the hospitals in the rural areas because I think that's really where the crux of the pressure on the health system is going to be. I can tell you from a resident perspective, from the rural areas, that same issue we've seen on lack of access to basic health care is exacerbated now, right? We've been really lucky as a state and on the federal level to have waived a lot of the restrictions on telehealth. And so that's another thing that folks need to know is that you can connect with not only your primary care doctor in a lot of cases, but also a behavioral health therapist using telehealth. So mental health issues, if you're suffering from some anxiety or depression. We're trying to expand that telehealth safety net as rapidly as possible to make sure that people in all areas of Colorado can get access to their doctor. But it's not a flip of the switch. So it takes some time to get that infrastructure set up. But that's a first step in helping the rural areas. And it looks like we lost Catherine, but I know that
sorry,
rural
my dog
hospitals
just
are
joined
also trying to step up.
My dog just joined us, so Leah says
How
hi.
are the hospitals doing? Oh, good.
Yeah, no, but if we've lost Ben, this is a perfect question for Ben. But
I've got him. I'm
oh,
here,
you're here.
Catherine.
Yay. Ben
Oh.
can be rural.
And do you want to weigh
I'm
in?
happy to. So, Andrew, I spent the last 10 years as a rural hospital CEO on the Kansas-Colorado border, and lived through the near misses and the maybe we'll make payrolls and the dips in volume. But I think it's important for folks to know that rural hospitals, the way they're reimbursed is how Medicare defines their cost. It's not necessarily how a hospital defines its cost, it's how Medicare defines its cost. So it's a reimbursement system that is designed to sustain rural healthcare delivery safety net providers, but not one that it's a cash poor model. So we see very commonly days of cash on hand for rural hospitals being somewhere between 50 and 70 days of cash on hand across the nation. Lauren could speak to this in Pennsylvania, I'm sure. There just isn't a lot of cash to be saved when if you're overpaid by Medicare one year, you pay it back, and if you're underpaid, they give you the difference. And so we find them being more vulnerable perhaps than the average hospital when they have to shut down the majority of their services, which are outpatient services. So they are losing, in Colorado, these organizations have lost 50, 60, sometimes even 70% of their revenue overnight as they did the right thing. Even though it was not required by the state, they did the right thing and shut down those outpatient procedures and other services. And so I'm receiving texts from hospital CEOs around the state that are saying, I just furloughed 20% of our workforce. Our entire leadership team took a massive pay cut. Some of us are going completely without pay for a month or two. Our doctors are whittling down their shifts or sometimes working as nurses, filling in, working as the doctor and the nurse to try to keep an organization going. I'm receiving texts that are saying by July 1, we will have 0 days of cash on hand. Those types of things are happening. And then in addition to that, of course, they need PPE and vendors are calling saying it's $8 a mask instead of $2 and all those things. So what they're trying to do is figure out how to avoid furloughing any more of their workforce than they have to, because that has major implications economically in their community and of course with poverty and things like that. So they've done that. Now on the flip side, I would say that it's been very remarkable for me and some of the donors, Project Cure and Make for COVID and others that are turning out PPE, to see how selfless these rural hospitals are. When we call and say we have this number of N95 masks, can you use them? They say, well, I actually only need half that many to get me through the next week, but I know my neighbor down the way needs more than I do because they have an outbreak there. Let's make sure they're covered too. And they don't hoard PPE. They're not hoarding resources. They're very selfless in the way that they work with each other. They are vulnerable. Make no mistake about that. They're definitely vulnerable, but we're seeing them innovate in really remarkable ways. And San Luis Valley and Alamosa is one example of folks that are innovating with the development or production of PPE and how they're using their workforce. Lincoln Community Hospital in Hugo is doing the same. I could give a dozen or more examples of folks that are really thinking innovatively about how they're going to weather this crisis and see their communities continue to thrive. But there are a few things: the way they're reimbursed, and then the fact that in most cases these hospitals are the largest employer. In many cases, they're the largest employer in their county. We need to keep a close eye on what's going on in rural Colorado, or as a state, we'll have some very different public health problems to deal with 2, 3, 4 years from now.
We're getting flooded with more questions that I'm going to have to cut off. So I'll just ask one more because it's a subject that grips me, the homeless population. We know in some estimates, 10,000 folks in Metro Denver might find themselves homeless on a given night. And across the state, we've seen too many people unable to find a home. What happens to that population? Who's taking the lead? I'll put the question to the panel and then invite another group of folks to join us at a future conversation, because I want to make sure that we don't shortchange that discussion, or for that matter, the question that Susan's asking about seniors who are living alone, or any of the parts of our population that are at risk. Is anybody in this group, though, working at all with the homeless population or familiar with policy efforts underway in that regard?
Yeah, Andrew, I would encourage you to think about a health equity town hall where you talk about health equity and how it's really showing its face, because it's almost exacerbated. We're seeing real time every day the injustices in our system and the impact that has on disadvantaged populations. So it's to the homeless, but there are quite a few populations that are suffering and going to die faster because of the way that our system is set up. So the homeless population, I'm so glad they asked about that, because it's an overlooked population and it is terrifying. They don't have any PPE, any protective equipment at the homeless shelters. They don't have hand washing stations. They don't have separate rooms. An outbreak at a homeless shelter is catastrophic. And so there has been a lot of work. First, you want to look to your mayor to work with them on shelters and finding extra space. And we're seeing that in Denver and in Colorado Springs, and I'm sure in other towns around Colorado. We just saw that the National Western, the Convention Center, is going to be, they're going to open up 600 additional beds for homeless. And that was Mayor Hancock who did that work. They're also working to identify hotels and motels. I think they had maybe 300 rooms. They need 3,000 to house the homeless. But really what state leaders are asking for is for Governor Polis to create a plan for homelessness under the coronavirus. And there was just a letter that several legislators sent the other day with specific requests on what they need to do for the homeless. And it was around that protective equipment for the shelters, the hand washing stations, housing the homeless, and then making sure that they're getting the testing and treatment that they need. But we would like to see a more coordinated effort from the governor. We know there's a lot of things to worry about and juggle right now, but we can't overlook this population.
We'll try to lure the governor or the lieutenant governor, whom I know pretty well, or some other policymakers onto future town hall meetings. So we have people on these panels who are also in a policymaking position. I want to say thank you to all the folks who have joined us for this conversation. I know there are many more questions than we could do justice to today. I want to make sure, to Elizabeth's point, that we dedicate future conversations to issues of concern, particularly to communities of color, to immigrant populations, to folks, a passion for me, folks who face mental health or substance use disorders, and continue this conversation online. You can do so at Romanoff 2020 if you follow me on Facebook or Twitter or Instagram Live. I'm not quite ready for TikTok yet. You can also find the invitation to future town hall meetings by signing up on our website at andrewromanoff.com, and you'll get instructions to join us by Zoom. Again, the Facebook and Twitter and Instagram handles are at Romanoff 2020. I know that everybody who joined us on this call today and everybody on this panel had other ways in which they could have spent their time. So I want to say from my heart to yours, thank you very much, not just for spending about 75 minutes with us today, but also for what you're doing every day to keep us safe and to improve healthcare in Colorado. It means a lot to me. I know it means a lot to the nearly 6 million people with whom we share this beautiful state. And I hope we'll not only overcome this crisis, I know we will, we'll get through this together, but I hope we'll also be able to build a system that benefits all of us in the future. Thank you all for sharing your time, and I hope you enjoy what is the weekend to come. Take care.
Thank you.
Thank you.